Welcome to Board Pearls. This is episode 3 of the Inherited Liver Diseases chapter and the Liver Disease module. This episode is the other inherited liver diseases: alpha-1 antitrypsin deficiency, cystic fibrosis-associated liver disease, polycystic liver disease, and the familial cholestatic syndromes. 4 diseases, each with its own recognition cue, its own treatment logic, and its own trap, and the unifying move is that mechanism predicts therapy in each one. Start with alpha-1 antitrypsin deficiency, the cleanest example of mechanism predicting therapy and the easiest place to get caught. Alpha-1 antitrypsin is a protease inhibitor, the brake wherever neutrophils release proteases into tissue, most familiarly the lung but also the arterial wall and skin, so losing the brake loses tissue. The high-risk genotype is PiZZ, whose single substitution prevents the protein from folding, so the misfolded protein polymerizes inside the hepatocyte and never leaves, dropping the circulating level to about 15% of normal. So the hepatocyte has a polymer load it can't clear, and the body has almost no circulating anti-elastase activity. That single mechanism splits the disease into 2 organs with 2 different problems. The lung suffers from circulating deficiency, and the liver suffers from intracellular accumulation, the same allele driving both, but the local lesions not being the same lesion, which is the hinge fact for everything downstream. Inheritance is codominant, not recessive, so each allele contributes proportionally to the level and the misfolding risk, which is why the common heterozygote isn't a silent carrier, running around 60% of normal and rarely causing liver disease alone, but amplifying any other insult, alcohol, fatty liver, or viral hepatitis. The recognition phenotypes go in tiers. The wild type covers most of the population. PiZZ is the highest risk at around 1 in 1,600 to 2,000 births. The compound S and Z heterozygote can present with liver disease because it carries one polymer-forming allele, and the common heterozygote amplifies other insults. Then the board favorite distractor is the null genotype, which produces no protein at all, so patients have severe early-onset emphysema because circulating anti-elastase is 0. But no liver disease whatsoever, because there's no misfolded protein to accumulate, since none is synthesized, so severe lung disease with normal liver enzymes and biopsy is the null pattern. And the stem is asking whether you understand that the hepatic injury is from intracellular polymer, not circulating deficiency. On biopsy, PiZZ disease shows eosinophilic periportal cytoplasmic inclusions that are PAS-positive and diastase resistant, and the diastase resistance is a mechanism cue, because diastase digests glycogen, and the polymer is misfolded protein, not glycogen, so amylase pretreatment doesn't remove the staining, which separates it from glycogen accumulation. And keep the iron stain straight, because Prussian blue stains iron and is the hemochromatosis stain, so periportal inclusions on the PAS stain point to alpha-1 antitrypsin, while Prussian blue positive material is hemosiderin and points to hemochromatosis. The natural history splits the same way the mechanism does. A notable fraction of PiZZ infants have persistent neonatal cholestatic jaundice, a minority progress to liver failure in childhood, and in adults the picture is chronic hepatitis or cryptogenic cirrhosis with a real cancer risk once cirrhosis is established. And although only a fraction of deficient adults develop clinically significant liver disease, among those who do progression is steady, which is why this is the most common metabolic indication for liver transplant. Outside the liver, 2 extrahepatic findings to recognize are arterial aneurysm with dissection from loss of the protease brake on the arterial wall, and a neutrophilic paniculitis. Now the treatment, where the mechanism trap lives. Intravenous augmentation with pooled plasma alpha-1 antitrypsin restores circulating anti-elastase and slows pulmonary decline, but does not protect the liver because the lung injury is from circulating deficiency, which augmentation reverses, while the liver injury is from intracellular polymer, which augmentation can't touch. So a stem asking whether augmentation alters the hepatic course is asking whether you understand the 2-organ split. The other trap is NSAIDs, which increase hepatic alpha-1 antitrypsin synthesis, meaning more misfolded protein in already overloaded PiZZ hepatocytes, so they're avoided regardless of liver disease stage. And a stem dropping ibuprofen for back pain into a PiZZ vignette is asking whether you noticed. Diagnosis is not on the level alone, because it's an acute phase reactant that rises with inflammation and falls with synthetic failure, so phenotyping or genotyping is the standard, confirmed on biopsy by the globules. Smoking and alcohol cessation are essential. Vaccination against hepatitis A and B is standard. And PiZZ adults get annual labs and imaging with cancer surveillance once cirrhotic, while heterozygotes don't need formal surveillance but get counseled on the modifiable risk factors. Transplant is curative because the recipient assumes the donor phenotype, synthesizing wild-type protein and eliminating both the polymer load and the circulating deficiency in one step. Now, cystic fibrosis-associated liver disease, where the mechanism is also a single chain, but the therapy stacks at 3 points along it. Cystic fibrosis affects about 1 in 3,000 births, and a fraction develop liver disease through CFTR dysfunction in cholangiocytes, impairing chloride and bicarbonate secretion into bile, so the bile becomes inspissated. Small ducts get obstructed, retained bile acids injure the epithelium, and the end stage is focal biliary cirrhosis. The clinical signature is cholestatic enzymes appearing in adolescence or young adulthood, with imaging showing heterogeneous echotexture and eventually splenomegaly. And the fibrosis being focal is the diagnostic problem, because a biopsy can sample a normal region and miss it, so diagnosis is clinical, supported by ultrasound and elastography in a known cystic fibrosis patient, with biopsy rarely needed. Cholesterol gallstone disease is also common from altered bile composition and impaired motility. Management has 3 parts, each at a different point in the same causal chain. Ursodeoxycholic acid is the most downstream, stimulating bicarbonate secretion and shifting the bile acid pool toward the less toxic form, dosed by weight. Fat-soluble vitamin replacement is the middle, addressing the cholestatic malabsorption amplified by the pancreatic insufficiency, because bile and pancreatic lipase are both required, and these patients are short on both. And CFTR modulators are the upstream intervention, chosen by mutation class, with the potentiator alone rescuing gating in the class where the channel is at the membrane but won't open. A corrector plus potentiator combination, pulling the F508del channel to the membrane and gating it. And the triple therapy combination, now the standard for any patient with at least one F508del allele, modifying the upstream defect and changing disease progression by addressing the cause. Transplant is reserved for end-stage disease, sometimes combined with lung transplant when both organs fail. So the pattern is one causal chain with 3 intervention points: downstream ursodeoxycholic acid, middle fat-soluble vitamins, and upstream CFTR modulator by mutation class. Now, polycystic liver disease, where the genetics fork early and treatment is driven by symptom severity rather than cyst count. In the autosomal dominant polycystic kidney disease context, it accompanies renal cysts, with most cases from one gene and the rest from another, both producing renal and hepatic cyst growth through dysregulated signaling in cholangiocyte cilia, driving abnormal proliferation and cyst fluid secretion. The autosomal recessive counterpart produces congenital hepatic fibrosis with recurrent cholangitis rather than the cystic adult phenotype, so kidney cysts with a fibrotic rather than cystic liver is the recessive pattern. An isolated polycystic liver disease without kidney involvement is its own dominant entity from genes encoding endoplasmic reticulum protein folding machinery, feeding into the same dysregulated proliferation. Most polycystic liver is asymptomatic and incidental and needs no therapy, with the imaging trigger to evaluate being more than 10 to 20 cysts, since a handful of simple cysts isn't the disease. Symptomatic disease drives treatment, and the symptoms come from mass effect, not synthetic failure, pain, hepatomegaly with early satiety, dyspnea from diaphragmatic compression, and biliary or vascular obstruction, with synthetic function usually preserved, which matters for listing. First line for symptomatic disease is a somatostatin analog, acting on the biliary receptor to reduce cyst fluid secretion, with a modest volume reduction that's enough to relieve compressive symptoms in many, and the right non-invasive starting point. When it fails, surgery is next. Cyst fenestration to decompress focal mass effect, and partial hepatectomy for refractory dominant cysts with adequate reserve. And transplant is reserved for massive disease or combined liver-kidney transplant in advanced kidney disease, supported by a MELD exception, because the calculated score reflects synthetic function while the patient is being slowly crushed by their own liver, so the score undercounts the morbidity and the exception corrects for it. Caroli disease and syndrome, intrahepatic biliary ectasia with congenital hepatic fibrosis, overlap here but live in the biliary material. So the pattern is straightforward. Genetics fork by dominant versus recessive, and liver-only versus liver-kidney. Asymptomatic disease needs nothing, and symptomatic disease escalates from somatostatin analog to fenestration to transplant, with the MELD exception because synthetic function is preserved while mass effect isn't. Now the last cluster, the familial cholestatic syndromes, which split clinically by the GGT pattern, by progression, and by cancer risk. The first two progressive types both present in infancy with severe pruritus, a low GGT, and progressive disease, but with different genes and mechanisms. One from a defect in a membrane-organizing enzyme that maintains the canalicular membrane's asymmetry, supporting the transport machinery, and the other from a defect in the bile salt export pump itself, the direct pump moving bile acids into the canaliculus, so bile acids accumulate inside the hepatocyte. Both are low GGT because the injury is hepatocellular rather than ductal, since GGT is a biliary epithelial enzyme released when the duct epithelium is injured, and here the duct isn't directly damaged, so GGT stays low even as the alkaline phosphatase and bile acids climb. The cancer risk follows the mechanism. The export pump type carries the highest pediatric liver cancer risk and is the one where an alpha-fetoprotein rise should prompt surveillance, because the intracellular bile acid accumulation drives both injury and oncogenic signaling, while the membrane organizing type doesn't carry the same load or risk. The third progressive type breaks the low GGT pattern from a defect in the flippase that secretes phosphatidylcholine into bile to buffer bile acids and solubilize cholesterol, so bile acids enter the canaliculus unbuffered and damage the biliary epithelium directly, which is exactly what produces a high GGT, and the failure to solubilize cholesterol produces intrahepatic cholesterol gallstones, with later onset because the injury is slower. And the benign recurrent forms are missense versions of the same genes as the first two progressive types, but with enough residual function that each cholestatic insult is followed by recovery, giving episodic cholestasis with complete normalization between episodes and no progression. Same gene, different residual function, different disease. Treatment is mechanism-led, and pruritus is the dominant, most debilitating symptom. Rifampin activates a nuclear receptor that upregulates bile acid metabolism and detoxification, shifting the pool toward less pruritogenic species, and naltrexone blocks the central opioid receptors mediating the itch signal, so they work on different parts of the pathway and are often combined. The newer therapy that reshaped pediatric cholestatic disease is the ileal bile acid transporter inhibitor class, which blocks the terminal ileum transporter that reabsorbs bile acids, so the enterohepatic pool shrinks, less returns to the liver, and there's less intracellular accumulation and less pruritus and injury, with one agent used for the progressive intracellular cholestasis syndromes and another for Alagille. Ursodeoxycholic acid has a specific niche, used in the third type because the defect there is in bile acid composition, replacing the toxic pool with the non-toxic form and partially restoring flow, while in the first two types the defect is upstream of composition, so it has limited utility. Medium-chain triglycerides and fat-soluble vitamins parallel the cystic fibrosis management, because the triglycerides bypass the bile-dependent micelle step, and transplant is reserved for end-stage disease, with the export pump type having a unique post-transplant complication the boards favor. Recipients can develop antibodies against the wild-type donor pump because their immune system has never encountered the functional protein, producing recurrent low GGT cholestasis in the graft, a mechanism unique to that pump because it's exposed on the canalicular membrane in a way that allows antibody-mediated injury. Alagille syndrome is autosomal dominant, with nearly all patients carrying a mutation in one gene and a small fraction in another, where the signaling pathway drives biliary tubulogenesis, along with cardiac, vertebral, and ocular development, so haploinsufficiency produces a multisystem pattern. The triad the boards test is butterfly vertebrae, peripheral pulmonic stenosis, and posterior embryotoxin, a thickened anteriorly displaced corneal line on slit lamp, with the characteristic facies completing the recognizable pattern. The hepatic component is bile duct paucity, with cholestasis and pruritus dominating, a subset progressing to cirrhosis, and the ileal transporter inhibitor is approved for the pruritus, which matters because the itch can be severe enough on its own to drive transplant consideration in a child whose synthetic function is preserved. So pull the four together, each with its recognition cue, and its mechanism predicts therapy logic. Alpha-1 antitrypsin is the dual-organ disease where augmentation rescues the lung and does nothing for the liver, because the lung lesion is circulating deficiency, and the liver lesion is intracellular polymer. Cystic fibrosis-associated liver disease is the single causal chain treated at 3 points, downstream ursodeoxycholic acid, middle fat-soluble vitamins, and upstream CFTR modulator by mutation class. Polycystic liver disease is the synthetic function-preserved mass effect disease escalating from somatostatin analog through fenestration to transplant, with a MELD exception recognizing what the score can't see. and the familial cholestatic syndrome split by the GGT pattern, and the cancer risk by mechanism, treated in the bile acid transporter inhibitor era for pruritus. The next chapter moves out of inherited disease into what cirrhosis does once established, regardless of cause, portal hypertension and the complications of cirrhosis, the hemodynamic thresholds and variceal screening, ascites and refractory ascites with TIP selection, spontaneous bacterial peritonitis and hepatrenal syndrome with terlipressin, and hepatic encephalopathy with lactulose plus rifaximin. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 3 of chapter 22, and I'll see you in the next one.